Hello, I'm Andrew Kaunitz, professor and associate chair in the OBGYN department, University of Florida College of Medicine in Jacksonville. Today I'd like to discuss how should we respond when endometrial biopsy for postmenopausal bleeding reveals proliferative changes. A 59-year-old woman with body mass index of 32 who does not use menopausal hormones presents with uterine bleeding. Endometrial biopsy reveals proliferative changes. This patient represents a clinical scenario often encountered by women's health clinicians. In menopausal women, we have traditionally responded to histopathology demonstrating proliferative changes by reassuring the patient that the findings are benign and advising that she should let us know if future bleeding occurs. However, a recent review published in ACOG's Green Journal details the implications of proliferative endometrial changes in menopausal patients, making the case that treatment as well as monitoring may be indicated. In premenopausal women, proliferative endometrial changes result from ovarian estrogen production during what we call the proliferative phase of the menstrual cycle. In menopausal women not using hormone therapy, in contrast, proliferative endometrial changes reflect aromatization of androgens by adipose and other tissues into estrogen. As in those diagnosed with endometrial hyperplasia, menopausal women found to have proliferative changes have an increased risk of endometrial cancer. A retrospective cohort study of almost 300 menopausal women found to have proliferative changes with endometrial biopsy and not treated subsequently followed participants on average for some 11 years. The mean BMI of these women was 34. The likelihood that women initially found to have proliferative changes were subsequently diagnosed with endometrial hyperplasia or cancer was almost 12%, some 4 times higher than women found to have atrophic endometrial changes. We know that oral progestin therapy and follow-up endometrial sampling is effective in preventing endometrial cancer in women diagnosed with the pre-malignant condition hyperplasia. In recent years, we've also recognized that the convenience as well as the high endometrial progestin levels achieved with levonorgestrel IUDs have advantages over oral progestin therapy in treating endometrial hyperplasia. Although both oral and intrauterine progestin are highly effective in treating simple hyperplasia, progestin IUDs are substantially more effective than oral progestins in treating complex hyperplasia. In addition, side effects including bloating, unpleasant mood changes, and increased appetite are more common with oral than intrauterine progestin therapy. Unfortunately, data from randomized trials addressing progestational treatment of proliferative endometrium in menopausal women are not available. The author of this review suggests that when endometrial biopsy reveals proliferative changes in a menopausal woman with bleeding, we should perform surveillance endometrial sampling every 3 to 6 months after initiating progestin treatment. If such sampling reveals benign but not proliferative endometrium, progestin therapy can be stopped and endometrial biopsy repeated if bleeding recurs. To me, this is sound advice. I'm Andrew Kaunitz. Please take care of yourself and each other.